excited to introduce Dr. Sarah Nietz to us. I was just with Paul Ruff earlier, and he was saying what a wonderful PhD scholar she is. Everybody was very excited to have you coming. So Sarah is a surgeon and also a leading specialist in the treatment of breast disease. She's led the Charlotte Makeke Breast Unit before establishing a multidisciplinary unit at Mediclinic Morningside. Her research focuses on both HIV and breast disease, and the quality of breast cancer care, in which she completed her PhD. She serves on various advisory committees and chairs the National Committee for breast trial and the subcommittee for breast centers of the Breast Interest Group of Southern Africa. So we're very excited because we do know in South Africa we have a lot of HIV and breast cancer coexisting together, and that there are obviously issues around inflammation, immunosuppression, and progression and outcomes. So I think it's a wonderful thing to be able to hear more about this.
As you've heard, I'm a surgeon and I'm not a scientist. I actually spend my daytimes operating, and I'm a clinician. And that makes my path a little bit unusual, and it hasn't been quite straight. So I thought I'll just take the opportunity to tell you how I got to where I am. I come from a country with universal health coverage, and I did my undergrad studies there and a doctorate, and life happened and I ended up in South Africa, and I fell in love with surgery because of its instantaneous results, and I thought, I'm going to be a trauma surgeon. And when I finished, I was drawn to the leading oncology role of breast cancer treatment and the very enlightened treatments, and I chose breast. And at that time we had choices and posts were already available, and I found myself in charge of a very big breast unit very early in my career, and I was really struck by the plight of the patients, oftentimes very poor, underprivileged, and yet they were mothers, breadwinners, and really were subject to very chaotic treatment that required, they really required something better. So I got to work and I basically trained myself, and I established a multidisciplinary unit there. And then I was given the lifetime opportunity, and I was asked to be a site PI on the SAPCHO study, which is the South African Breast Cancer and HIV Outcome Study. And obviously I agreed, and after about 2 years of participation in that, I thought, right, I'm going to do a PhD. And I'm clinical, I like pragmatic things, I wanted something with impact. I also feel we need to think what is unique in a low to middle income country, and what can we really contribute in terms of unique data. And I thought, I'm going to focus on quality of care. And I was sent to Germany, and I did a travel fellowship there, and I met interesting people who I still collaborate with. And then life happened, and I had a boy, and I was not given the opportunity to take down my hours, and I found myself then in private practice. So it wasn't out of choice, but I left. I was still an honorary lecturer for a while, and I wanted to continue the PhD, and I think this is the unique thing, is that you can have a full-time job, you can be outside of Wits, and you can still finish this. So I completed this, and this is only the start. I've got lots of ideas, and I think it's opened so many opportunities in terms of what we can do going forward. We all know the slide. So basically in South Africa, breast cancer is the most common malignancy, and most countries show the same, but it's a little bit more complex than that. We're seeing quite an increase in incidence, and we have a very unprepared healthcare system for that. So we would predict that there's going to be a doubling in overall cancer cases by 2050. And the elephant in the room is really that our patients are having disproportionately high mortality rates. So in high-income countries, we're looking at about 85 to 90% all-stage survival, and my own data shows 43% over 5 years. Discovery data is 84%, but I'm sure they've got probably some precancerous change numbers in there as well, so I'm not sure that it's quite as high as that. Beyond just incidence, it matters. Our patients survive, our morbidities linger. It's very costly treatment, both for funders but also for families. And women have a very special role. They're center of families, they're breadwinners, and overall in the world, over 250,000 children are maternally orphaned due to breast cancer. And in a society like ours, where most children do not have a dual parent family, this is particularly relevant. It's also really complex because not every breast cancer is the same. We've got rapidly evolving treatments. You've got sequencing of treatment that changes. So you really need to know what you're doing. You're also trying to marry these core specialties, all very small egos, and we're all very easy to get along with. But traditionally we work in silos, but in fact we should be working together. Also the patient is like a ping pong ball between these specialties, and it needs navigation. It's really widely accepted that we should be treating breast cancer in multidisciplinary teams and that you should see specialists. So for instance, if you see someone like myself, you are likely to have a third reduction in risk of death at 5 years, which is massive. I mean, it's the same as a drug that we sell for R1.5 million to treat a single patient for triple negative breast cancer. That's the same kind of relative risk reduction that we're talking about to train a breast surgeon for a year. And obviously it's not just how we cut, but it's actually that the breast surgeon obviously works in a multidisciplinary team, and we do the right thing at the right time, and we get everyone who needs to treat breast cancer involved. Beyond just the core team, we have all sorts of other things that we should have: palliative care, genetics, research teams. You need a breast nurse, someone needs to collect data. So it's not really such an easy task to do this in an effective way. Classically, the patient in the public sector will come with symptoms and will end up with a breast surgeon, and then there's tests that are done, they're reviewed, more tests are done, then there's a multidisciplinary team discussion, and then the treatment is sequenced. And sometimes it's appropriate to send first for systemic treatment, and sometimes we operate. And then generally there's, if indicated, radiation or even other treatments adjuvantly. But behind all of this, wherever you are, whether it's my private practice or in state, you're also dealing with very vulnerable patients. And while we're making treatment decisions, they really want to know, am I going to survive? How am I going to survive? Will I see my children grow up? Can I have children? And what is your treatment going to be doing to my body? So it's a lot to factor in, and obviously it's best to do this in teamwork. Nevertheless, I mean, when we treat early breast cancer and we do it right, the treatment can be very successful. The ABC-DO study, and I saw you actually circulated that, over 416,000 deaths are predicted in sub-Saharan Africa in the next decade, of which we could prevent at least a third if we get treatment earlier and we get better access and improvement in care. So the provision of care, so access to optimal therapies or waiting times, they probably make a difference of about a third of these survival differences. But we have to be careful that it's not just universal access. So if we don't up the quality of care, it's going to contribute just as much to mortality as having no access at all. And obviously also the lack of guidelines, quality control, or regulatory frameworks. We think it's probably about a quarter of these survival differences as well. whatever we want to do in our setting, in LMICs, we have to make sure that it's actually implementable and feasible so that it can be impactful. And I think South Africa is a unique country where we really have a wide spectrum of resources. But even in the private sector, it's not endless, and you must realize that resource constraints apply throughout. And people always think that the standard and the majority of women who get treated for breast cancer is the high income standard. And the truth is, we think that in future, particularly, most women who get treatment for breast cancer will be in low to middle income countries. So if we define quality of care, it's basically how your healthcare service will increase the likelihood of a good outcome and is consistent with current professional knowledge. And the classic Donabedian model looks at process, outcome, and structural indicators. And in general, process indicators are the easiest to capture and to look at. So that would be if someone had breast conservation, how many of them got radiotherapy. Structural indicators show, for instance, how you deliver the care. Do you have enough resources? Do you have certain therapies? And then the outcome indicators is really the gold standard, but it's very hard for us to get because of long survival times, and oftentimes you need about 20 years of follow-up to really comment on these. Obviously, that's a very basic model. So if you look at modern cancer care, this was what I based my conceptual framework on, and these are 12 further domains of cancer care. And this looks at structural, process, and outcome measures, but also in view of innovation and improvement, and looking at value. So not just the cost, but also patient-reported outcome measures and experience measures to look at what can be achieved with these therapies. So look, it's quite a mess, isn't it? I mean, when we think about how am I going to solve things, how am I going to make things better, I can't unravel everything. But I felt I wanted to tag just on a few of these, and I was driven by, firstly, we've got these high mortality rates. We really need effective interventions. There was this dearth of data. There was one publication from Rwanda on adherence to quality indicators. There was a single publication from China that defined their quality indicators. There was absolutely nothing, no previous measure of any quality of breast cancer care in South Africa, or any cancer care as a matter of fact. And there were no quality frameworks. So we hadn't set indicators. We also didn't know what would define a center in our setting. And we do have a breast cancer policy, which was published in 2017, and it was actually quite progressive, and a lot of us actually worked on that. But none of it has been implemented. And the big question is, would adherence actually affect survival? And I wasn't sure, because obviously this is heavily influenced by the late stage presentations that we're seeing, and quite erratic healthcare system delivery. And my hope was maybe I can find a key indicator that would offer a target for feasible and effective interventions, and hopefully also inform policy. So I was just going to tag on a few of these strings, and I thought, let me tag on quality control, outcome data, and standardization, and maybe some of these other things would unravel as a result. It is Pinktober, and everyone's got breast cancer on their mind, and I saw at Woolies you now get pink cups. And don't get me wrong, I think awareness is very important. It gives us language, it gives us visibility, but unfortunately this often stops at symbolism. And for the people who actually treat these women, and I've accompanied thousands of women through this, it's a very hollow conversation, and I think this conversation must change. Our patients are not dying because they don't have access to a screening mammogram. They are dying because of the poor access to care and the poor treatment quality that they often get. So I think this is a wonderful article. It just came out a few days ago by my formidable colleague Liana Root, who's in the Western Cape. And South African women, we deserve more than this, and it's time for open conversations and reality in these pink months. And this is the story, and this is my husband's slide, and it's stuck with me, and it was partially also part of the motivation, and it's very busy, but it tells a story of a patient who tried to get help. And there were 10 healthcare contacts, 3 admissions before the patient finally got help, and it's the kind of this Kafkaesque journey that our patients have to get through to get to treatment. And unfortunately, the end result, and I apologize for sensitive viewers, but the end result really is often like this. And this is not, this is not an outlier, but we saw this quite commonly. And look, I think that access to care and how we can get people to come earlier is very important. And it's studied, and I think it's a unique opportunity for research in South Africa, but it wasn't my interest. I wanted to see that we find accountability for what we do, and that we track what we do, and that we measure it. So I was going to then focus on quality of care, and if I found anything, hopefully that would make a change for everything else. So this is basically the oversight of what I've been doing. I did a mixed method study, and basically there were 4 separate objectives. I first set a local QI set through a modified Delphi process. I then applied this to a large cohort to get a benchmark of the level of adherence. I then looked, does it matter? Is there a key indicator that we could unlock to make a change? And a little bit later, we kept going back to the multidisciplinary team, so we actually also brought in the requirements and an implementation plan for South African breast centres. And look, I mean, mixed methodology has its ups and downs. For me, it worked. I think it's very intuitive for clinicians, because that's what we deal with every day. So you always, even if I see a patient, there's qualitative and quantitative data. And for me, it gave a very rounded look on this problem. So the first publication was to set the quality indicators, and this happened quite a number of years ago. And it started with a very time-consuming systematic review. We got an expert panel, and then we had this modified Delphi process. But we got so many indicators that we actually then stratified them by levels of evidence. And basically, the expert panel was quite representative, and we ended up, after everything, with these 10 mandatory quality indicators that we all accepted that we're going to look at. These are the indicators, and basically they're all quite reflective of the different steps, basically from diagnosis over to the operation, radiation, and multidisciplinary discussions. And yeah, then, look, I mean, I had a child, I left Wits. I can't tell you how lucky you are to have protected academic time. I have a very busy private practice. I had my first child, and then I had a second child, and COVID hit, and the whole world went mad. And I tried to keep everyone as safe as possible. I had my second child during the first COVID wave, and as fate wanted it, my mother also was diagnosed with metastatic breast cancer and passed away. And I think just for 3-4 years almost, I couldn't look beyond my own plate. And but I kept thinking about it, and I wanted to make this change. And I am actually quite grateful for that pause, because it gave me a lot of reflection, and sometimes you have to think about things before you can move forward. And then things happened, and I thought, it's now or never. And I think within a year, just over a year, we finished the PhD thereafter. So we applied it to the cohort, the South African Breast Cancer and HIV Outcome Study. It's NIH grant funded, and it's the largest sub-Saharan African cohort to date. and I was in charge of Charlotte Matleka Breast Clinic at the time. We then did the benchmark, and look, I mean, it was over 3,500 women that we applied these indicators to. Very important, we didn't design the database to actually measure quality indicators, so I had to go and find the data through other ways. We graded also. I was interested in, can we measure it, and how good was going to be the quality of data going to be. And look, I mean, HIV is part of it, so I thought, let me better check that adherence levels weren't affected by HIV status. I think it's super important to realize that we used the database differently. So at Charlotte and at Barrow, we use this for all our record keeping, meaning that we've got such granular data, and we had way more research staff as well. And I can't tell you how important it is for clinicians to have research staff to get good quality data. So look, we just noticed that there was some differences between the quality. I tried to make it more scientific by looking at how data was entered, how it was structured, and if there was ever a cleaning process, and then graded the data quality. And we found that we could actually measure most of the quality indicators retrospectively through our database, not reoperation rates. That was dreadful, so we just couldn't get it right. But most of it, we actually succeeded with it. And this is what it looks like. This is your snapshot. So you've got your international standard levels, and then we've got our South African standard levels. And we identified critical gaps. So very low breast conservation rates, sentinel lymph node biopsy. It was not available at some of the breast units in South Africa. I mean, it's bizarre. Receipt of radiotherapy, particularly in Gauteng, and we've all heard about the radiation delivery crisis that we had here. Barrow patients, 40% of them who had breast conservation never received radiotherapy. And we could definitely do better with MDT discussions, and we need histopathology reporting standards. So I was very chuffed, actually. I thought this was unique. I wasn't surprised by the poorer results. If you look at European, how they started, it was quite similar, in fact. And it reflects the process of starting quality control. Thankfully, HIV didn't have an effect on adherence levels, because that would have complicated my thinking process a lot. And in terms of electronic records, obviously, it would be much better if we find a way that we can look at these quality indicators in real time. Because knowing about the radiation delivery crisis 5 years later is not as good as having an overview and a snapshot in real time. And then this is my favorite part, and I haven't published it yet, but it's ready. And basically, I wanted to delve further into, does it make a difference? So I wanted to assess the effect of individual QIs, also to develop a composite QI model, and then also analyze whether the resource constraints that we had made us change our treatment pathways. In high-income countries, generally, their patients survive a lot, and they don't have a lot of events, and their quality of care is so high that they use composite models. So there's really little data on individual QIs. I certainly couldn't find anything from low to middle income countries, and my hypothesis was I'm not going to be able to measure anything, if at all, maybe the composite model, because I thought it was going to be too chaotic. We had just over 2,700 patients, and I'm very grateful that we had the research staff who ascertained vital status, and we really had a very rigorous approach to the data here. We did sensitivity analysis, so I learned a lot in this, and then a stepwise progression, first looking at odds ratios, and then hazard ratios, basically uni and multivariates. And then we developed a composite model, which sounds very easy, but in fact, not every patient, this QI adherence applies to them. So we had to calculate where does it apply, where does it not apply, and we had a model with 0% adherence, under 50%, and over 50%. And obviously we also looked at survival and the differences in the treatment pathways. To understand the differences in treatment pathways, this is not a good slide for this, I hope you can see it. In Gauteng, we had great theatre time. I mean, Herbert and I, you came to our clinic, you were operated next week. We just made it happen. So we had good access to theatre, fair chemotherapy access, but very limited radiation access. And that was very different in Durban, where they only had one surgeon, one theatre list. So that was really the biggest constraint, but they had good access to chemotherapy and fair access to radiation. As I said, I mean, we couldn't measure reoperation rate and case volumes. I mean, goodness me, we had so many cases. All of us were above what is internationally recognized. But we did add timeliness because that's a new indicator that in my 3-4 years of reflection came to the fore. So we added this into the mix. Look, I mean, we looked at the risk factors, and this is exactly what we see in all our publications. So we look at the stage, HIV status, and then tumor biology factors. And because we've got such big patient numbers, there was actually a measurable difference between all the sites, and we've seen this again and again in our publications. And this is what it looks like when you follow a patient through, and it shows just how much these patients have to go from one side to the other, and without navigation, how they would get lost. But the big thing is that radiation, we had to change our treatment pathways because we couldn't access radiotherapy, and I'll show you a little bit more in detail. So, for instance, in Durban, they didn't have access to operations, but they had access to chemo. So most of their patients started with chemo, or they put them onto anti-hormone treatment, whereas we operated whatever we could. And if you look at what radiotherapy did, you would always expect radiation to be your second or third treatment. But because of the big delays, most of our patients had radiation as a fourth treatment. So actually we found that we used endocrine treatment or chemotherapy to bridge our patients to radiation. This is our overall survival. It's only 43%. I mean, that is comparable to 1960s Europe, and it's very sad and not okay. So we need to really work on that. These are the survival curves. If you look at the stage, that's not surprising. Early versus late stage, HIV, we've always seen that it obviously affects overall survival. And I was so grateful to see that the sites were all the same. I mean, we didn't do well, but at least we made a plan, right? So it shows the resilience in these systems, and that all of the sites actually, with whatever modifications we did, we came out with similarly poor survival rates. So I wasn't sure if I could figure out the impact on survival, but this is the composite model. So that was very reassuring, that you have an almost 3 times higher risk of death if you have no adherence to quality indicators. And then we looked at the single indicators, and we actually found quite a number of them had an independent effect on survival. And these are the most important ones. So the radiotherapy issue, 82% higher risk of death at 5 years. Also, I mean, many of them didn't even get it, but if you got it, it was a median time of 154 days, which is way more than the recognized 3 months. And this is a key delivery, and these should be measurable in real time going forward. This is my proudest discovery, and this is that if you were not discussed in a multidisciplinary team, your risk of death was 48% higher. And I think this is the key issue. So this is this is a implementable and very high value intervention that we could do in low to middle income countries to change and close the survival gap. And that brought us to breast centers. And I mean, we cheated a little bit because actually I got ethics to, I had to reapply, and I said, look, I thought about this and I actually need to standardize what it means to have breast centers in South Africa. And we know this concept very well from Europe and from the United States, and it's got many good effects. And in general, if you have internal or external accreditation processes or even just audits, your quality of care is going to increase over time. Now, for ideal functioning in Europe, they say you need 1 in 250,000 population. We've got different incidence levels, so I calculated it to 750,000 total population, which means we need about 80 breast units in South Africa, probably percentage-wise slightly more in the private sector because of different incidences, but we definitely way behind. There are accreditation systems, and there's one from the United States and from Europe and from Germany, and those are the most prominent, and we can apply them here, but the question is it really relevant? Are we having the same standards? And it's unfortunately not affordable, and therefore it's not widely reproducible. Again, a slide from my husband. So this is a slide from the time of fees must fall, and there were more burning universities than breast units in the country. And if you think that it's better in the private sector, think again, there's not many more. So at the moment, we've got under 10 on each side. They were part of the guidelines, they haven't been implemented, and it's really left on both sides of private and public the issues of under-resourcing, a complete lack of transparency, and I think particularly in the private sector actually, and canvassing. I mean, you can call yourself whatever you want. You can say, I'm a breast center of excellence, and yet you operate maybe on one of them, and it obviously misleads the public, and there's no governance around this. We also need to improve our capacity, not just breast surgeons, oncologists. I mean, we really need these centers for training, and we need to think out of the box, and we started to say we need to find private and public partnerships to bring this forward. As I said, I think the public sector has actually more robust academia and governance. The private sector has way more resources and no excuse, and unfortunately governance is equally poor. And you are really subjected to a very variable quality of care depending on where you go. There are obviously benefits, there's challenges. I think the benefits outweigh the challenges. I've put cost effectiveness as a challenge, but in fact, if you look at healthcare economics, it is cost effective. But in the private sector, unfortunately, the private practices bear the costs of running these MDTs by themselves. So things have to change to facilitate multidisciplinary care on both sides. So I thought about what do I want to achieve and what are the issues. So the issues are cost, the validity, that we don't have anything what is relevant in South Africa. We don't have transparency around data, and structurally we need to have increased capacity and the training. So this was, I think, our most political paper. I learned a lot in terms of merging different interest groups and trying to find common ground. And I think it's a very nice paper that we published quite recently. And this is the first time that breast center requirements were defined in low to middle income countries. And look, I mean, I had been thinking about it for a long time, and I basically started taking these standards from the 3 accreditation systems and putting them into tables. And it was just massive, these documents. And I managed to bring it down to 8 major components. And then I asked very prominent people to review from each of the specialties. So we had the president of SASCO, the president of SASMO participating, and others. And then we had this expert panel, and we chose to have the clinical experts but also advocacy, and we did get funders involved as well. And we came up with a consensus, and basically we looked at clinical prerequisites, and those are things that you can really implement without a lot of cost. It gives you a stepwise approach on what to do to improve your structural component of quality. Then we need institutional support, and look, I'm lacking that as well. I mean, I see over 400 breast cancer patients who are newly diagnosed per annum, and I have zero support from my institutions. And we need to find a way to actually measure this data and have electronic records. And we found that Begoza would be the best place, so the Breast Interest Group of Southern Africa, to have a central repository of this data, and to then find a way of going together with audits and quality control and improving our outcomes. And these were we have to start really low, so these are 1 or 2 indicators that we set per treatment modality, which will give you a very real overview of under and over servicing as well. And well, this has actually brought other things to the fore. So it's been endorsed now by Begoza, SASCO, and Cancer. We've got a working group. We had a massive implementation meeting with funders, managed care companies, the oncological societies. I mean, I think there were over 54 representatives there, and we've agreed that Begoza is going to be the central repository. We also have people who do want to collaborate and, as they call it, are getting Begoza ready. And I think we have to have a very collaborative approach to get this going. And interestingly, the person that I spent some time with on my travels actually contacted me and said he wants to be involved. So we've identified him as someone who would be ideal as an international coordinator. It's also brought the European Cancer Organization to us, and USOMA, who have offered patronage for this. And I think it's an exciting prospect, and I'm trying to find funding mostly from the private sector to pull this off. So there's going to be a lot of work with that. We're still in the preparation phase, and I'm meeting lots of people and having fun trying to set this up. And I sincerely hope that I can, and that we can make this difference. I also think that in terms of the quality of data that we would get, it would open so many doors in terms of implementation, research, etc. So it would be an exciting academic prospect. And then once I had everything, there's always the integrated discussion, and Shane Norris is my supervisor, so I had to think completely different and triangulate my evidence, which I did, and it's mixed methods. So look, we learned from each one of them, and I think it's given us a very good overview of the problem and solutions to go forward. I think MDTs certainly is a critical aspect. It was interesting to see also the resistances to change, especially with our paper around breast centers and how to navigate that. The empirical themes that sort of came out of that is how do we close the outcome disparities, and key interventions, and I feel that the role of the surgeon is very central, and we need subspecialization, and we need to bring breast centers forward for structural change. Again, mandatory MDT discussion is the process indicator that is key going forward. I think that all these barriers to implementation can be navigated, and in the end, I've actually seen that most people want to collaborate and they want to see a change. From a funder's perspective, they want value-based care, and I think it's coming, and I'd rather lead it from the front than from the back, and I think it's something we need to all think about. And look, I mean, we got lots of info out of this, isn't it? So when I revisited the conceptual framework, I was quite surprised that we had data on most things, but we also found that we need to up our game on some things. We can't comment on cost, and that would be so exciting looking at healthcare economics going forward. We don't have proms or prems. So those are things that we really need to get better at. So in conclusion, South African women have disproportionately poor outcomes, and we need change. So we need a real cancer policy. It needs to be implemented. We need advocacy for that, and the conversation that we're having in Pinktober needs to become less shallow. We need access to all treatment modalities, and we need to actually monitor these as key deliverables, and so that we can action them in real time. The MDT approach, as I said, is critical, and this is my key intervention that I would suggest. For the private sector, we need to find ways to incentivize people to do this, and we are in conversations with MedScheme and Discovery around that. And I think from a structural point of view, we need to increase training and capacity. These breast centers are key. It's not just breast surgeons, but also the whole oncology workforce that we need to expand with that. Breast always is the first, and if we can pull this off, prostate, lung, colon, they can all follow. And I think, look, we are about 25 years behind what Europe has done, and it's time that we find solutions that are feasible for our setting. It's uncomfortable to change. We all sitting in a situation where we have our ups and downs and our benefits, but we need to use foresight, and we need to implement these new care paradigms. It's going to take a lot of collaboration between all interest groups, and I think we all need to be transparent in what we do and inclusive. Yeah, I've hit some hurdles. There's vested interests, ethics, governance. I'm still looking for the perfect sponsor and partnerships, but I think it's really an opportunity to standardize care and a huge opportunity for research. I'm very grateful for the time that I took out to do this PhD. I did it between 2 and 6 a.m. I'm a mom. I have a very busy private practice, but it can be done. And I think it's a privilege to be able to think about something in such detail. So whoever is contemplating about a PhD, I can just say, yeah, it's worth it, and I would do it 1,000 times again. And I hope that this has laid a foundation of better knowledge and improved outcomes for people beyond what I can do with my own hands. And thank you, and I love discussion.
Chair, I always get the first question. But that was brilliant. So besides being a very busy surgeon doing your PhD, maybe you could PhD and being a mom, maybe you can also be a mentor as well, because I think you're a great inspiration and a great example of how to balance clinical care with research. So that's great, and a very busy clinical practice. So I had two questions. So with a 43% poor survival rate that we have in South Africa, it seems that a big indicator, besides the lack of multidisciplinary care, is the lack of access to radiation. And if we had more radiation, we would improve our outcome, because if we're only getting radiation on the 3rd or 4th time, that's the biggest marker, besides lack of MDTs that I can see. So we could change this like this if we had radiation. So that's my first question. And then my second question is around, the indicator that you took out, which was the amount of surgery you were doing. So my question to you, like in obstetrics, the more babies you deliver, the better you are as an obstetrician. Is it the same with surgeons? The more breast resections you do, the better your outcomes. So those are my two questions.
Yeah, I think radiation is a big issue. I think it's being addressed, But I think it's also a surrogate for overall functioning of healthcare systems. I don't have data on systemic therapy, which is hugely important, and it's just, it's one of my limitations. But yeah, it's certainly a key deliverable, and it has to change, 100%. I'd be interested to look at what our patients are doing now in terms of radiation, and waiting times are not always translating to real life patient experiences, which is what we've looked at. So we were talking about looking at whether it's changed with the implementation of hyperfractionation, and Devern's doing a great job trying to bring down the waiting times. Definitely, you get better as you progress. Yeah. So the more you do, and that's part of, the more granular parts of what we've defined as a breast surgeon, is that you have to probably do at least 50 operations a year to be considered as okay. And I even found that it's little. We do way more than that. And I think it's a learning curve with all surgical operations, yeah.
Thanks, and thanks, Sarah. I must say, just from a personal point of view, it was actually really great supervising you through this PhD. It was, of all the ones I've done, I think was the most stimulating. So well done. I think the thing that comes across, well, there are many things, but I think it's one of the biggest problems we have in this country when it comes to healthcare delivery is the complete lack of cooperation between doctors and the system. And we see that at many levels, between the private sector and the public sector. We see it between and a problem specifically to here, between the university and the province. Even internally, we see problems between Krisani Baragwanath and Charlotte Mujeke, we see problems. And I think that, it's, in theory, it should be very easy to fix, but unfortunately it's not. If people learn to work together, it would go a long way towards fixing a lot of the problems. But unfortunately, there are lots of egos, and there are lots of stumbling blocks. There are political problems, there's access problems, and I think you've shown very clearly how important it is for people to work together. And I think it's something that we really need to encourage, and I think what you've started is a good way of trying to improve this for breast cancer, but obviously into other areas. But sometimes it does get frustrating. Just from the radiation point of view, Glenda, it's actually quite sad, because in the private sector there are probably too many machines out there. But the problem in the public sector, and particularly here in Gauteng, where up until now in southern Gauteng it's only been at Charlotte Mujeke. There is, hopefully we'll have machines at Christmas soon, but it was a mess because the Department of Health bought machines without planning properly. Hopefully you'll have machines in there. And then the other big problem in the public sector is the staffing. And that many people like Sarah, for example, many others, who qualify, who want to contribute, but there's no post for them. So they can't even do things in the public sector. It affects training, it affects everything that's being done. So, there's lots of terrible hurdles, but I think that hopefully the more collaboration, the more people work together in this university, in this province, and in the country, the better we can get when it comes to cancer care in general. And the one thing that makes it even worse is that breast cancer is probably the best managed cancer there is in this country. You look at other cancers, it's worse. Lung cancer, for example, is horrendous. GI cancers, cervix, prostate is much worse. Breast cancer is the best managed because there's the most insights into it, and that's because of the activists and that. But there's at least more awareness of breast cancer than any other cancer. So, as you're right, it's a start, but we've got a lot more to do before we can really get to solve all these problems. Thank you.
And Paul, I do think also, those 43% is at the top breast centers. So imagine what happens to patients in Kimberley or Bloemfontein. I mean, Bloemfontein, I hear, they don't do breast conservation at all. They don't teach it. They don't have access to it, and that's, you know, the way it is. So there's lots of places that are even worse. Yeah.
Got 2 questions.
Well done on your PhD.
Thank you.
The question that I have is on the MDT team. Was it only medical doctors? Did you think about maybe including the rehab staff? Because it's not only what happens at the hospital, but people go home. And I love the way you started your presentation, that these are mothers. These are, you know, they need to go back to life. Did you think about maybe adding the MDT? And if you did not, what are your thoughts about adding the MDT, the therapeutic, MDT team?
So we've got the, thank you, and it's 100% correct. I hope you saw that I spoke about the core team. So those are the treatment modalities and the diagnostic modalities. So that's like the, you can't do it without, right? Okay. But we actually have, we did say who's in the extended team, also in the publication. So definitely palliative care, rehabilitation, dietitians, fertility preservation. I mean, it's like, on my personal MDT, or not personal, on the academic MDT that I am on, Paul will tell me it's not really academic, but there's over 30 people on that call every time, and we try and get everyone in to give the most holistic care.
Only 75% of breast cancer patients are hormone receptor positive, so there's 25% where hormone therapy is of no benefit at all. And I mean, it is an option. I mean, another option obviously is chemotherapy, but the real issue is not that. The real issue is that if people work together, we'll be able to get past this. And I mean, there have been hurdles at every point, and the radiation, I mean, you did say has improved, and I think one good thing with radiation has been this concept of hypofractionation. In other words, giving less fractions rather than more is to give, and that has improved things with machine time. Also, I think with the whole approach in the department has improved. You know, there's been this whole scandal with the Gauteng Health Department radiation. In fact, in reality, things are much better now than they used to be. So in some ways that they missed the boat when it came to that, because I think the approach things have improved. They're not perfect, but they have improved, and hopefully now, if they finally get this machine into at Barra, which is sitting in a warehouse waiting to be installed when they dig the bunkers and put it in and get the staff. I mean, I believe, you know, because that's another problem, is the staff and the training of the staff. That's a problem. But I think things are looking up compared to what they were before. However, it is still a problem. And the other last thing is what you said, is that that's great in Gauteng and even in Durban, but you know, you go to the more rural parts of this country, you look at what goes on there, and that's another whole nightmare in itself, because in reality, when it comes to cancer care, if you're outside Gauteng and the Western Cape, it's very limited.
Yeah, the
So
same in private.
carry
You
on. No,
outside
exactly.
the 10-kilometer radius, it's the Wild West. So,
But that's a different reason. That's because people do what they like. Whereas there, it's because people don't do anything because they can't do anything. But you are right. So, I mean, but, you know, you're going to solve this all overnight. And I think you have to do things in a stepwise fashion. So I think we're getting into the right direction. There's going to be a long way to go.
Yes, I mean, I think the quality indicators are an integral assessment of how we change over time. And so it's very good that we've got these quality indicators to measure ourselves with, and then to see what are the predictors of improved outcome. You were skeptical about, and my last question, then we're going to go and have food and drink. My last question is around the private sector. So you were skeptical about the discovery rates, and you said it might be because there's a lot of pre-cancerous things that they are obviously attributing. What do you think? So taking that out, and maybe when we get access to the discovery data, we can start to look at what are the predictors of success in a so-called better system, and what do you think
So the issue is codes, just to start off with that. So they only have the code. So there's a code that's DO5.9, and that can be a stage 1 breast cancer, stage 0 breast cancer, but it can also be a risk lesion, which is LCIS, and they're mixing everything together. And that's why I'm saying I think that their outcomes are a little bit worse if you really interrogate it. In terms of the indicators, I feel they must be exactly the same, and that is why it was a public and private collaboration. And Discovery feels they should be the same, and we should be measuring that. I do think that early access makes a big difference. I mean,
Time to
obviously,
diagnose.
stage is going to be is the big difference in that, and I think that in the private sector particularly, we must start thinking beyond just survival, but also quality of life, patient-reported experiences, and you're going to struggle to get survival differences because people do a bit better. I mean, the only reason I think why we are seeing such differences is that our patients die. I mean, we've got so many events that statistically you're going to find more indicators. But I think we're going to measure the same. That was at least our intention. Yeah.
Thanks. Paul?
Just two quick comments. One is that ICD-11 is meant to be coming to replace ICD-10. Warwick Sib is working very hard on that, which will be a lot better. ICD-10, as you know, is from the 1990s, and so it makes a lot of what we do very backward. The one other area of research which I think is becoming really important is health economic research. I'm actually just starting to supervise a PhD with Sue Goldstein on looking at health economics of breast cancer care and looking at Barrow, Charlotte, and Discovery data. And I think it will be very important because that's something that there's a lot of work needed in cancer care is the economics.
Yeah, that's excellent. Well, thanks very much for this, and we really appreciate you coming. So please come and join us and allow you to network with the students and other people who you can inspire to continue to do clinical work and become a clinician scientist. So thank you very much.